Thank you everyone for joining me tonight. I really appreciate your time. What I hope this presentation will provide you is really, this isn't an academic presentation, it's not lots of literature. This is really focused on some of the experience and the pearls of wisdom that I've learned over the past decade of using DolorClast in my practice. And I think it's a really powerful tool. And I'm going to talk a little bit about basically how I implement Shockwave to really optimize the results, because often the patients that I learned most from early on in my days using Shockwave were some of the ones that I didn't get results with. I was not happy with the results the patient got. And I think it's the reflection on some of those that really comes into forming some of the treatment algorithms that I use. So for this presentation, I'm not going to go through a lot of the basic sort of physics and the basic concepts behind Shockwave. So we do have on our EMS DolorClast website, the Australian one, we have an education and training section there. And through that, you're able to book basic training. And this can be used for teams, but it can also be used for small groups. So if there is people that are new to Shockwave, or you've got new team members that have just joined, this can be really helpful in terms of, this is where we can go through some of the real fundamentals of implementing Shockwave into practice. So the first thing is really, what is tendinosis? And the way I see tendinosis is it's effectively a breakdown in the tendon, and it occurs when the cumulative load effectively exceeds what the tissue can take. And there are tissue changes which are apparent. They can sometimes be apparent palpably, such as with mid-portion Achilles tendinopathy. We can feel that palpable fusiform thickening of the tendon. We can see those changes on ultrasound as well. We can see an increase in ground substance in the tendon. We see the tendon becoming disorganized. And we can start to see increases in vascularity. So we start to see tissue changes. The thing that our patients are coming in to see us often is because they've got pain and dysfunction. And it's typically the pain that results in dysfunction. And it's often when that gets to a point where it's starting to impact things that they enjoy in life. And this might be things like looking after family members, this is exercise, this is work, it's all of those things. So tendinosis, plantar fasciitis, these sort of degenerative soft tissue musculoskeletal injuries, they cause sort of considerable impact on our patients' lives, and I don't think that should be underestimated. So the first thing to understand about sort of tendon biomechanics, and this is one of the first sort of graphs I remember from our biomechanics training. And what we're looking at here is we've got stress on one, and this is tendons act like a viscoelastic structure. So you can almost think about them being like a very, very tight elastic band. On this axis here, we've got stress, and we're looking at the other axis, strain or elongation. So as we apply a load to a tendon, when that's up to about 2%, the tendon is sort of uncrimping. It's going from a relaxed state to a taut state. From about 2% up to 4%, it's operating in the elastic zone. And this is where, when the load is taken off the tendon, it's going to return that energy, and it's also going to return to its prior length as well. Once we go beyond about 4%, what starts to happen is we start to see plastic deformation. And this is where the interlinks in our tendon start to break down. This is where collagen fibers start to fail, and we start to see tissue damage. What also happens as well is when you remove the strain or the stress, the tendon no longer goes back to its original shape. It's in an elongated state. Something to take, and if you look at this, let's say, for example, this white line is my tendon, my Achilles tendon capacity at, say, age 20. Now, this changes over the course of our life. So at age 45, for example, my tendon might represent more what this red line looks at. And you can see now the threshold for where this tendon starts to plastically deform changes considerably. There's a considerable drop off. So it's partly why when I work with a football club, even though I'm dealing with this is a typical age of the guys is sort of late 20s to early 30s, I can still see things like plantar fasciopathy, Achilles tendinopathy, these type of injuries. These are almost unheard of in a 16-year-old athlete. I can't remember a single, fit, healthy 16-year-old who's presented with mid-portion Achilles tendinosis. When we have a look at this is on an electron microscope. This is looking at, basically, this is a lateral collateral ligament. When that is stretched and strained past that 4%, this is what it looks like. And you can see the fibers are becoming disorganized. This is really what starts to happen. And this results in changes to the tendon, both physical, biomechanical, and cellular changes. So things that affect our tendons biomechanics, their age, from the age of about 28 onwards, we're no longer producing the same amount of collagen and elastin. So our tendons start to degrade. The same thing is we can often look at, we can tell someone's age within a ballpark figure by looking at their face. And what we're looking at really in terms of wrinkles and things like that, it's the deterioration in the collagen in their skin that we're looking at. That is happening internally as well. That's why people who are in the middle of their life are more prone to these tendinopathies. Things like BMI play a role as well, and comorbidities such as diabetes. This affects our connective tissue. Smoking affects our connective tissue, and in particular the metabolic syndrome that we see, which is dyslipidemia, hypertension, insulin resistance. Tendinopathy can be a warning sign for those patients as well. There's a high prevalence of people with, which is really endemic in our community at the moment, of people with tendon disorders, tendinopathy, and things like that, who also have the sort of, the triad of insulin resistance. They're pre-diabetic, they're hypertensive, and they've also got high cholesterol as well. In the literature, this is shown to be a correlation. So where does shockwave come into practice? Ultimately, this is an interesting study. It's not a large study. It looks at 58 patients and 70 tendons. And this is looking at people with mid-portion Achilles tendinopathy. And it's a follow-up of the Alfredson's heel drop protocol. And it's over a 5-year period. This is why I liked it. And it found that at the end of a 5-year period, 60% still had pain. And 48, close to 50%, had tried one or more alternate treatments. So there's the problem. We know that many patients fail conservative physical therapy. They fail exercises. There's a range of reasons why patients might not progress. Sometimes if a tendon's painful, they may have fear around that. Compliance is another one. There can be a whole range of factors, but we've also had, and I've had patients that have been extremely compliant with their exercises. They're those really type A personality types, and even despite following a proper protocol and proper loading, they're just not progressing. And I think shockwave is a treatment that is really, I think it makes very logical sense. It's a treatment that has a solid evidence base to it. But also in the decade of using shockwave, I've never had a serious adverse effect from it. It's an extremely safe treatment for our patients, and it often provides quite immediate results. The other thing is that often when patients, and traditionally when patients have failed physical activity and their physical sort of rehab protocol, a cortisone injection might be considered. This particular graph, what we're looking at here, this is a study looking at, I think, 88 patients, and this is specifically plantar fasciitis. And it was a randomized control study where both the patients were blinded to their intervention, and so was the person providing the intervention. It was an ultrasound guided injection of either saline or dexamethasone, which is a type of steroid, which is a potent anti-inflammatory. And over the course of a 12-week period, there was a statistically significant difference at 4 weeks, but that was the only point throughout the course of treatment where the control group who received the saline versus the group who received the steroid. So steroid has a role, but it's a short-term pain reduction. And there can be cases where this may be considered. I had a patient several months ago who, when I saw her, a corporate woman, very, very well educated, her life had changed quite considerably. So she has a very high stress job in the banking sector. She's recently been married. She has a young child. She's got some stepchildren, and she had a really chronic heel pain that she'd seen her GP for. She'd seen 3 GPs for, and basically been told, look, it's going to get better in 12 months. Here's a few exercises to do. By the time I saw her, she was in such a state. She was crying through the consult. This was really compounding, and it was in a very, very acute on chronic sort of situation. And in her case, because it was affecting so much, it was more for her, and it was a discussion around, let's just get the pain down. She wasn't at a point where she would have probably tolerated a stimulus like shockwave, but that calms things down for a while, but it certainly doesn't fix the problem. And we still then have to work on all of the other treatments we have to get in place. The way I talk to patients about shockwave is it's like hitting the reset button. Sometimes on our computers, despite doing all the right things, trying to shut the programs down, it just isn't responding. And these are the patients that you've given them exercises to do. They have done these exercises for a period of time, and they're getting to a point they're not progressing. Okay, well, they still have pain, and maybe pain is what's limiting them from continuing. So I describe to my patients that shockwave sort of hits the reset button on these injuries, and this can be really helpful for these chronic cases. And there's 2 types of reset that I explain to them, and they have different effects. One is we're resetting the software. And resetting the software is where I'm talking about the reduction in pain that patients feel immediately after treatment. And this is the depletion of substance P. This is the desensitization of the area. This isn't the healing response. So I say, when you've had a chronic injury, what happens is that that injury gets into a really chronic pain cycle. And then that starts to cause dysfunction in terms of the way that you move. Patients are limping. You've got muscle spasm. You've got all of these counter type issues. When you shockwave a patient, for example, a really good one for this is like a mid-portion Achilles tendinopathy. Almost as soon as you shockwave them, they feel better. Now, nothing has happened structurally. There's not been structural healing that's taken place, but this is sort of that resetting of that pain signal. It's getting them moving back, breaking those maladaptive movement patterns, and this is the software reset. The other thing in terms of the hardware, this takes longer. So I'll tell patients that first off, what you'll feel is that after this treatment, and I'll change this depending on what specific condition I'm treating. So for example, Achilles insertional tendinopathy, it doesn't respond as quick as mid-portion does. So you have to factor that into the way you set the patient's expectations. But that initial pain relieving effect, I tell them that, look, after the treatment, this is going to feel really good. And for the next 24 to 48 hours, I don't want you to do any really strenuous exercise on it, because it can give you a false sense of security. We're not at a point where that healing's taking place. The capacity in the tissue hasn't improved at this point. What we want to do is you're just out of pain. So I want to protect them. I want to, get them moving again in a more normal pattern. What takes a bit longer is and that will wear off a little bit between the course of treatment. So I'll tell them, look, you'll feel really good for a few days and you'll still feel better than you did often before we started. But when I see you again in a week's time, some of that's going to wear off a little bit. Now, the more longer lasting effect is really what we see 6 to 12 weeks later. And this is consistent with the research as well. When you compare shockwave to an intervention like a cortisone injection, in that first 4-week period, cortisone, because it's a potent anti-inflammatory, can have more of a pain relieving effect, but shockwave will do better and shockwave does do better at the sort of 3-month, 6 months, and 12-month period. So you explain to patients, and most patients don't want a quick fix. They want to get things better. They want a longer lasting effect. And that's been shown in the literature. I also talk to patients about shockwave being like a course of medication. So just like antibiotics, there's no point if I've got pneumonia just taking 1 dose of antibiotics. It's a waste of time. But there's also no point taking, antibiotics for months after the infection's resolved. Shockwave's a little bit the same. In order to get into that therapeutic range with the intervention, you need, I would say, depending on the severity, anywhere between 3 to 6 sessions. Most commonly for pretty much 90% of things, I'm doing 4 to 5 sessions. Once you go beyond 6 sessions, it's diminishing returns. The patient's not necessarily, you're not getting incrementally more of an effect. What I will prefer to do if I'm dealing with something more chronic is I will do a course of treatment, whether that's a 5-6 session course, and then I'll give the patient a break, and I might do a top-up session in a month's time, and then I'll space those top-up sessions out a little bit, as opposed to just weekly shockwaves. That's just, so I explain it to patients being like a course of treatment. And sometimes these analogies just help set the patient's expectation, because if you don't set their expectation, they will have some expectations anyway. They will develop their own expectations. And if it doesn't meet their expectations, that's when they're often left disappointed. And they may drop off your treatment, your management plan. So some of the mechanism, in terms of the mechanism of action, our shockwave activates the C fibers, and these C fibers release various neuropeptides such as substance P, calcitonin gene-related peptide. We can get over various neuropeptides that are released. It also increases lubricin, which is more so for joints, that has a lubricating effect, which can help, which can be wise in sort of osteoarthritis. It can have pain relieving and also improve the movement. And these neuropeptides, they're biologically active. They can activate stem cells, as in chimal stem cells, fibroblasts, and sort of osteoblast cells as well. So this is a really interesting study back from 2005, and effectively what they did was they used radial shockwave, like our DolorClast. They looked at 86 patients with painful heel pain, and they broke them up into 2 groups. One group received a nerve block, a tibial nerve block, and the second group just got the shockwave without the nerve block. Now, the interesting thing is that there was a considerable difference between the 2 groups. The patients who didn't receive a nerve block did considerably better. So that correlated to, and what they looked for in terms of a significant improvement was a greater than 50% reduction in the patient's symptoms. Now, the group who received the nerve block, only 29% of them had a greater than 50% improvement versus 67% in the group without the nerve block. So that sort of goes in to show that the nerve, that blocking of the nerve was, it was creating, it effectively lowered the efficacy and the efficiency of the treatment. And it looks like the reason for that is because what it does is it blocks the stimulation of the C fiber. And when the C fibers are active with shockwave, they release those various neuropeptides. This particular study, and the same author had gone back to try and work out what was going on there. And basically they used people's forearms, and what they would do is on one arm, they would shockwave with no local anesthetic, and then on the other arm, they would shockwave with local anesthetic. And what happens here is this is looking using a sophisticated technology to measure blood flow. You can see that you didn't get the same flare in terms of increase in blood flow, which also sort of flows onto metabolic activity. So when you blocked the release of those neuropeptides, it also dampened the response of shockwave. And substance P is also a proliferative. People think about it purely around pain, but it does also create, it's also biologically active. And what happens is that substance P increases the proliferation of human tendon cells. So this particular study, what we're looking at is cells that were taken out of a human Achilles tendon, and they were cultured. Now, in one group, they've added substance P to the culture, and in the second group, there was no substance P. And if we have a look at 4 hours after the culture was set up, the fraction of these tenocytes, these Achilles tendon tenocytes from humans that are proliferating was 30% versus 15% in the control group. So the addition of substance P causes an upregulation in proliferation. This here also shows the ability to nullify that. So when you add neurokinin 1 receptor blocker, this is an antagonist, this is a drug that blocks the receptor so that substance P can't act, you actually stop that effect. So what you're showing here is the direct correlation between substance P causing that increased proliferation. And this is really interesting. So I think that substance P does help with that sort of software reset, but it also does help in terms of increasing the metabolic activity and the proliferation rate of these cells. When it comes to getting good outcomes with shockwave, the primary thing is it comes down to fancy technology does not replace clinical expertise and a thorough clinical exam. It's important to have an accurate diagnosis. If you've got an incorrect diagnosis, for example, you've a misdiagnosis between an insertional Achilles tendinopathy versus a retrocalcaneal bursitis being the primary thing. Retrocalcaneal bursitis, shockwave's not going to do a whole lot for. This is more of an inflammatory friction-based problem. So getting the diagnosis right is really important, and factoring shockwave into an overall treatment plan is where this comes into effect. So I really take time to properly clinically evaluate patients so that I can understand when is best to time the introduction of shockwave. And this has a considerable impact in terms of whether patients do well or not. In some cases, I've seen patients who have come in with a various problem and they've been treated elsewhere. And they come in and say things like, well, I've had shockwave and it didn't work. And ultimately, the diagnosis hasn't been correct, or it's been implemented at the wrong point in their treatment plan. Just to reiterate some of the contraindications. Contraindications to shockwave is anticoagulation therapy. Things like low-dose aspirin, I don't take as a absolute contraindication. I've treated patients on mild levels of anticoagulation therapy. In particular, I would use some common sense around that. When I'm treating, the majority of things that I'm treating are all lower limb. The plantar fascia, patellar tendon, the gluteal tendon. These things are not overlying major vessels. You're always using a very low, I'm always sort of starting at a very low intensity. And this is very different. If I'm dealing with someone who's in their 40s, who's on low dose aspirin, this is different to somebody who's in their 80s, who's on warfarin. Completely different in terms of that. So anticoagulation therapy is a contraindication. Pre-ruptured tendon. This is important in terms of not that shockwave has been shown to cause tendon ruptures, but when you've got that level of tendon damage, often shockwave can be used, but it's all around the timing. You've got to get some cellular healing there first. If you've got fluid, shockwave can't act on fluid. So if you've got a decent intrasubstance tear in a tendon, there's no point shockwaving that right now. You need some fill-in of scar tissue, a scaffold for those cells to work off. Lung and gut, recent cortisone, and this is about 6 weeks. Again, There is no specific evidence that says that that shockwave after cortisone is detrimental, but it just hasn't been researched. And the cortisone, due to the potent immunosuppressive and anti-inflammatory effect, is likely going to reduce the effectiveness of your treatment. Pregnancy, like most things, pregnancy hasn't been studied with shockwave. So although there is no study showing harm, there's also no study showing that it's safe. So we err on the side of caution. Local infection and tumours is quite self-explanatory. So some of the things that I consider a positive predictive value for shockwave, and these are patients who, when they've got these things, I generally know they're going to do well on average. And these are patients that have had pain for greater than 3 months. The pain that they have is stable and localized. And by stable, I mean that, they're the sort of patient that will say, look, throughout the day, it might be uncomfortable, but look, first thing in the morning when I get out of bed, my heel is really sore. It takes about, a few minutes for it to warm up. But then throughout the day, I'm sort of okay. It does bother me if I sit down for too long and get up. When I go to the gym or I go for a run, if I've overdone it, it's really bad the next morning. These are the sort of patients that it can be really well for. You're also clinically able to localize that pain through palpation and also sort of, clinical evaluation. And they should have some tolerance to palpation pressure. If they can't tolerate light palpation, then they're not ready for shockwave right now. They're not going to tolerate it enough to be able to get enough of a dose into the tissue, and that's going to ultimately affect your efficacy at the end. And they should have some load tolerance. So these are people that are still able to move, they're still able to do things, but they've got some restrictions and some functional limitations on that. If they're unable to weight bear, for example, they're not ready for shockwave. And the implementation is just, it's not the right time. When it comes down to things that I consider negative predictive value, and a lot of this is my clinical experience. These are things that I've associated it with not necessarily having the best outcome. And some of these are changeable. Just because someone has something that I consider a negative predictive value right now, I can often get to them the point, whether it's a few weeks' time, a month's time, where they're good candidates for shockwave. And that completely changes the outcome. So unstable pain. These are patients that they can't seem to work out what aggravates their pain at all. The pain, even on light days where they're not that physically active, they've got severe pain. I'd consider that quite unstable. Nocturnal pain. Patients with nocturnal pain, it's important to consider things like, generally with nocturnal pain, I'm thinking bone pathology, I'm thinking stress fractures, I'm thinking stress reaction, bone tumors, those type of things. You will see, however, in tendon tears, these acute on chronic tears where someone's got tendinosis of their Achilles tendon or they've got plantar fasciosis. They can go from an acute on chronic presentation. And this is where the tissue can actually develop a tear and it becomes more inflammatory. And it's not uncommon for these patients to have nocturnal pain. So if someone comes in with heel pain and they've gone from having reasonably stable heel pain, and then they'll say, look, I can't really work out exactly what did it, but I was away last weekend, I did a lot of walking, and now my heel's really sore. I'm having trouble putting pressure on the ground. It's been aching a little bit at night. Because I do a lot of ultrasound scanning in the clinic, 95% of the time, I'll find there's either significant delamination or a tear. And then associated with that is some inflammation. So they're almost in more of although it's a chronic degenerative condition, there's an inflammatory component at that particular time. Pain that's poorly localized. You've got difficulty palpating, working out exactly where it is. If you just think about that, where are you going to target your shockwave? That can be hard to do. Considering the biopsychosocial considerations, and this is, the total impact of a person's social environment, their mental health, their state of mind. This is particularly important because all tendons are attached to a person, and that person lives in an environment. An example of a patient where I was a little bit this is last week, where she was doing reasonably well. I'm dealing with an Achilles a tibialis anterior insertional sort of tendinopathy. And this patient was doing reasonably she was reasonably stable, and we were progressing quite well. But all of a sudden, her symptoms really started to shift, and things were sort of deteriorating. However, she wasn't doing a whole lot more. Ultimately, I've got quite a good relationship with her, and it really come down to the fact that she'd gone through a really tough time. Her dog needed to be put down, and that had really affected her. And even though it was sort of a month to 6 weeks after that, she didn't have children, and her dog was a really big part of her life, and that really impacted her ability to deal with pain. So it did affect things. So considering those, sort of the full picture. Again, severe pain that's poorly localized, and poor tolerance to palpations. So if with just very light pressure, the patient can't tolerate it, they're not going to be able to tolerate the shock wave at that particular point. There are techniques that I use to desensitize patients so that they're ready. And I'll talk about those in a second, but repeated cortisone injections, again, are also not a great indication in terms of someone's success. So I will treat people who've had maybe, a cortisone injection or two, but I will change my probably expectation a little bit about their response. Their response may take longer to happen. And at that point as well, it can, with a lot of treatments, be a little bit diminished. When it comes to the sort of tissue, this is an ultrasound, and in this particular view, we're looking at a long axis view. So this is the heel bone here. We've got the plantar fascia inserting into that heel bone. We've got the fat tissue here, and we've got the skin. Now, if you've looked at a few ultrasound of the plantar fascia, what you'll recognize is that this is quite thick. It's also quite hypoechoic, meaning there's a lot of fluid in there. And we see these delamination tears. And when I look at the short axis of it, and this is the same structure looking in short axis, we can see the heel bone here. We've got the plantar fascia through here. And if you see the consistency of that, it looks like Swiss cheese. So we've got delamination. When I look at an ultrasound like this, this sort of patient I really change my expectations, because particularly if they've got pain that's quite severe, someone like this, they often need to, these are the sort of acute on chronic presentations that you'll see, where they've gone from having heel pain for 6 months, it's been relatively stable, and then all of a sudden it's deteriorated. And you'll often find when I ultrasound them this sort of thing. Because we've got some tearing there, there's nothing for the shockwave to act on in this area. So what I like to do is I like to brace them, I like to protect it in order to get at least some healing response. What happens is once you bring them back down to a more stable position, where their pain's more stable, that's when they're then good candidates for shockwave, and that's when I implement it. So the take-home message is really this is very much about the timing of the intervention, and taking those things into consideration. The timing can make all the difference between whether you get a good outcome or a bad outcome. And by bad outcome, I'm not meaning that the person's had an adverse effect. I'm meaning more that you just didn't get the clinical response that you wanted for the patient. So timing's really important. It's a little bit like, say, planting the seeds for a crop. It's all about the timing. It's a bit of an art to that, and that's what farmers particularly spend quite a bit of time on. If you mistime that, seeding your the grounds, you may change. It could be the difference between the outcome that how good that crop is that year. And it's a little bit like that, I think, with shockwave. So some things to take into consideration is the dose. And I look at the number of impulses. The number of impulses for most musculoskeletal things that we treat is between 2,000 to 3,000 shocks. One thing that's interesting in the literature is fibroblasts are more sensitive to the number of shocks than the actual than the energy. So when just in lab conditions, when they shockwave fibroblasts, it was the total number of shocks that tended to decrease the viability of them, not the actual intensity of the shock. So if that's broken that down as high pressure was okay, as long as it was for a reasonable, for a reasonable period of time. And in these lab conditions, they were doing things very in excess of what we would do in patients, like, well and truly over 6,000 shocks. Looking at the pressure that you can use. So ultimately, when it comes down to things such as taking into consideration where the anatomy is that you're treating. If I'm treating the insertion of an Achilles tendon, it's a very superficial structure. I don't necessarily need to get my pressure, up to 4 bars. Whereas, for example, the heel, I'm going to want to try and get that up a little bit. I'm going to want to get that over 2 generally, because you're dealing with a significant, fat pad underneath the heel. So just so I can get more energy into that area. The frequency is going to affect a few things. So frequency, generally, lower frequency will give you better penetration. So if you want something, you're treating something deeper, lower frequency. And this is the number of hertz. So for example, I'm sort of considering when I'm treating most things in terms of tendinopathies, round about the 12, from 8 to 12. If I'm treating the insertion of Achilles, I'm treating more at 12. Something that's a bit deeper, like the greater trochanter, I might treat it at a lower frequency, more around 8 hertz. And considering the course of treatment, like I mentioned before, you do have a sort of a therapeutic window, and doing more sessions isn't necessarily going to improve. You get diminishing returns. So, doing 20 sessions isn't necessarily going to get you a whole lot more effectiveness than doing 6 sessions. So frequency affects the depth. So higher frequency, if you're treating up like 20 hertz, it's going to lower your penetration depth. And that's fine if you're trying to desensitize something. So if someone's got a lot of pain and they're very, very sensitive, that's when I'll use really high frequency, because it's easier to tolerate, and I will use lower pressure as well. So if the patient's very, very sensitive, using that combination can be really helpful, using a high frequency and low pressure. If I'm really trying to get in and help with a deeper tendon structure, that's when I'm going to use a lower frequency, and I'm going to tend to drop the hertz down so I get more penetration. Muscle tone as well can be dependent on, so again, if I'm treating muscle, treating at a higher frequency above 15, we're sort of able to start overcoming the Golgi body tendon reflex, and that can have an inhibitory effect and reduce muscle tone. So when I'm trying to reduce muscle spasm and that sort of tightness, that's when I'll also use a really high frequency, 15, 20 hertz. That can be very effective. For healing, for tendon healing, what I'm generally using, as I mentioned, was a frequency between 8 through to 12. And this is where we're trying to stimulate cellular repair. And I'm spacing those sessions every sort of 7 to 10 days, but generally as close to 7 days as possible. Sometimes in your sometimes if I'm dealing with a tendon that's potentially someone who's got a very non-responsive tendon, I might increase that and actually do it a bit shorter than 7 days. If you're dealing with, so that's something that you can use as well. If they're just not responding, I might shorten that if they've got a really long-standing history of, mid-portion Achilles tendinopathy. So some techniques in terms of improving the tolerance for patients. On the first session, don't start on the side of maximum pain. Let the person get a little bit used to it. So mark and palpate the site that you want to put most of your energy. I usually will add on the first session, an extra 500 shocks on there so that I can start it at a really low intensity, 2 bar or just below 2 bar, just so they get an understanding, they listen to the sound. The sound can sometimes give people a fright. And then I gradually work towards that site where most of their pain is. And then when I'm on that, we start to increase it. It's also really important to, again, when I'm discussing to patients, explaining to it beforehand, I'll say, look, shockwave can be a bit uncomfortable. And sometimes that first session can be the worst because it's when everything's most sensitive. But it's okay. I'm going to start it on a really low intensity. And I'm going to talk to you throughout, and we're going to gradually increase that, but you're in control. So if you're feeling a little bit too much discomfort, you just let me know and I'll turn it down a little bit. Also, when I'm on an area, what will happen is when I move the shockwave machine, you'll have a bit of an increase in pain, but then after about 15 or 20 seconds, that will dissipate and the pain will drop considerably. So giving people and explaining to patients those expectations can be really helpful. If the patient's having trouble tolerating it, use a higher frequency. Generally is less painful for them. When I'm dealing with things that are close to, say, for example, the insertion of the Achilles tendon, I tend to like using the larger applicator, the 36 mil one, because it can be quite a large tendon insertion. So one, I'm getting a bit better coverage of that, but also I don't need as much penetration. I very, very rarely use the 36 millimeter one when I'm treating, heel pain, plantar fasciitis, plantar fasciopathy. I tend to stick with the sort of, our standard applicator. And the reason being is because with such a thick fat pad, using that broader handpiece, the applicator, I'm going to lose a bit of energy in the fat pad itself. Whereas the Achilles insertion, I'm not worried about that. When I'm treating around an enthesis as well, just like an insertion of an Achilles, I do a technique called, we do it in ultrasound. It's called creating a standoff. It's where you use a big blob of gel. And you don't actually, what I'll do is use a big blob of gel. I will apply the shockwave applicator in the gel, but not touching the patient. So I might be holding it, 3-4 millimeters off the patient, but it's still sitting within a big blob of gel. And because their skin and also the applicator is both covered in gel, that shockwave is still able to penetrate, no problem, but it does alleviate the pain. So for the first minute or so, I treat like that. And then as they become comfortable, you slowly lower the shockwave applicator to their skin and they don't even notice it. So that gives you the chance to desensitize things, and it does improve the tolerance. It's important as well to stabilize the limb. So patients like when you've actually got a hand, you're holding it firmly. It also helps with the reverberation. So I tend to grip and I'd like to put things on traction a little bit. So if I'm treating an Achilles tendon, I will often have the patient lying on their tummy and I use my knee to put to plantar flex their foot so that the Achilles tendon's under a little bit of tension. When I'm shockwaving, say, the plantar heel, again, I'm going to grip around the heel circumference and I almost pull a little bit on it because it dampens that reverberation. Sometimes patients will complain of discomfort, not so much in the area that you're treating, but they're feeling a reverberation in the ankle or further through because the shockwave is dissipating into those tissues. And a consent form, I think, is very important. And the main reason a consent form is important is because it sets out the patient's expectations. I like to, just like I explained to patients, I have that conversation around setting the expectations before we do that. So the patient's almost sort of that they're committing to that course of treatment. There's no point starting the treatment if the patient's not committed to doing that. And a consent form really just sort of one for financial consent, but also running through the contraindications and all of those things can all be on that form. So I think it's really important to use a consent form to create that with patients. Fantastic. So do we have any questions? I hope that was helpful. If we've got a few questions, we can run through those.
Hi, James. Thank you so much. That was fabulous. I learnt a lot. So I'm sure we're all really looking forward to putting a lot of your tips and tricks into action. We have a question, and I'll wait. Oh, yep, we've got a couple more coming in. What is the most number of shockwave treatments you would administer, given the standard protocol is 3 to 5 treatments?
I will generally do up to 6 for a course. And if I'm dealing with something a bit chronic and the patient's responded well after doing 6 sessions, what I'll tend to do is space those out. So I might say, look, we'll touch base in a month's time, and we might do just a top-up session. And I sort of space those out a little bit throughout the course of the next 6 months or so. But that's something that I probably don't do a lot of the time. If the patient's not responded to 6 sessions, I would really be going back to the to the drawing board and making sure that you've gone through diagnostically and that it's the right sort of thing. Because in most cases, if the shockwave's timed at the right point, and you're dealing with an indication that shockwave is appropriate for, you will get a response. So if you haven't got a response, I tend to think about that as well. I do always explain to patients too that, look, after we've done a course of treatment, if you have a bit of a flare up here or there and you're having trouble getting that under control, I do talk to them about doing a top-up treatment. And this is where we don't have to go through the whole course of treatment again. We don't have to go through 5 sessions or 3 sessions, but we might just do 1 or 2 sessions just to settle it down. So commonly I might do, let's say 6 months later, I've treated somebody, they've had a flare up. We might just do, 2 sessions, just to settle things down, maybe 6 months later, if that's the case. A small percentage of patients will need this.
Fantastic, thank you. And someone's just said, can you give another? So I'm assuming they want you to give another webinar there. So that's very
Perfect.
positive.
We can do that.
Definitely. Have you used shockwave for IM bursitis?
No. I haven't used it for IM bursitis. Potentially, generally for things that are bursal related, it's a friction problem. So there's potentially, again, I think you probably will find. I haven't. I tend to be more. For IM bursitis. My general approach is similar to most, is I try to address the mechanics of the instability. You've got the medial column of the foot, the lateral column of the foot, most commonly in that 3rd IM space. So I try to stabilize that area so there's less friction. If they're not responding to that, I do tend to use sometimes, more injection therapy for those type of things. You potentially, generally with bursal type issues, if it's a bursal type issue as your primary diagnosis, I don't think shockwave is going to be that effective. Potentially, if you're dealing with a very fibrosed sort of neural bursal complex, you might have more of an effect there. But yeah, I personally, I haven't done a lot for IM forefoot type stuff.
How does shockwave play out in the treatment of heel spur issues?
In terms of, look, shockwave I use very frequently for heel spur issues. So let me just go back. What I'm going to do is I'm going to go back to a slide. Okay, so this is an ultrasound here. This is a heel spur. So we've got part of the medial tuberosity here of the calcaneus, and this shelf of bone here is the heel spur that's developed, and the heel spur is really a shelf of bone and what I get frustrated with is you'll have academics say that the heel spur is not the cause of pain, and I completely agree it's not the cause of pain, but it's also not irrelevant. I will tell you in doing ultrasounds, finding hundreds of thousands and thousands of heel ultrasounds. When someone develops an intrasubstance tear, it's almost 95% of the time right here, because what happens is you get a compression functionally as the fascia wraps around the heel bone. You get a compression in this area, and that starts to break down the fascia. And you see the same thing with Achilles, insertional tendinopathy, the problem with the Hageland's deformity. It's the compressive load from that heel spur. So the shockwave doesn't fix the spur, but it does help with the damage that's caused from the spur itself. And look, these can be, we do find spurs in people that are asymptomatic and don't have heel pain, but like anything in life, bone is very responsive to stress. And when we have a very large heel spur there, I can infer that there's been, some considerable stress on the bone for it to have responded in such a way. But it's just interesting that you'll tend to find, 95% of the time, it's the deep insertional fibers of the fascia that tear, and they are always usually at the leading edge of the spur, and that will create, as the fascia becomes thickened, it will create an increase in pressure on that area, and it tends to delaminate in that spot. So shockwave can be helpful for the, it's not going to necessarily change the shape of the spur. These become pretty, this is corticated bone. It's very, very difficult to, nothing's going to break that down. Sometimes in the very, very early stages where maybe you've got some very subtle bone remodeling, it may have an effect, but I don't think the spur is the primary cause of the pain. The spur is relevant because you do find that puts pressure on the fascia.
There's another follow-up question here. So James, where would you treat in relation to the heel spur if not on the spur?
I always treat, I basically treat at the insertion pretty much. So it's right where it sort of, it drops off. Again, you're looking generally for maximum tenderness. I treat that sort of plant, I'm treating the area. So my shockwave would be pretty close to the spur because I'm treating almost that, that osseous ligamentous insertion point. That's where I'm tending to put most of the energy. So you are going to be treating in that area. I was talking more about probably the effect that it's going to have. It's going to have an effect on the fascia. It's going to help with that. It may not change it's unlikely to change the shape of the bone or anything like that. But yeah, I would still be treating that, again, to palpation pressure as well. You can, in clinic, because I've got access to ultrasound, I can often do a scan and really pinpoint where I want to treat. But in most cases, really the site of maximum pain. That's why a good physical exam is important. And it's also good to mark it onto the patient before you start, because as you start treating, there's going to be a desensitization in the area. So once you start treating, the point that was maximally tender as you began treatment will no longer be tender. So then it can be harder during the treatment to find that. So it's using sort of your anatomical knowledge and surface anatomy.
Fantastic. Have you had patients who have not had the expected short-term results, yet you have gone through the course of treatments based on your confidence in diagnosing the indication, but yet still had the expected long-term results?
Yes. Yep. Yeah. Once you've, and that's what I do explain to patients, is it can take time. Particularly the insertional stuff. When you're dealing with more an Achilles insertional pathology, I will tell those patients they're not necessarily going to get the same response that the mid portion will get. Mid portion I love treating because the success is probably 98 it works very, very well if it's timed right. The other thing that I do as well is I don't like to overload my patients too. So when I'm doing the course of shockwave, I'm not progressively loading them at that point. I'm not giving them heaps of exercises to do. I really try to protect them through that period. So I do still use things like, good quality supportive shoes, bracing, strapping, all of those type of things to protect them. I'm generally not putting a heap of load on it. Once it's settled down considerably, that's when I sort of start to load them. Potentially early on, I might use a bit some isometrics here and there, some isometric loading just to maintain. But I don't like to overcomplicate things and have too many interventions going at once. Because if you're shockwaving at the same time you're trying to progressively load them with a rehab program, it can be very difficult to work out what's helping and what's not.
That makes sense. That makes sense. When will you prescribe eccentric exercise after shockwave treatment? And which conditions did you have the most success using this modality?
So I will use eccentrics and loading generally closer to the end of the course of shockwave. Sometimes I'll complete the whole course and then move into a rehab phase. So I like to get my patients to about 75% improvement in their symptoms, probably before I start loading them. That's a general thing. So I like to usually finish, probably after 4 or 5 weeks. I might give them some, as I said, some basic isometrics and things like that, but I certainly don't want to give them anything that's going to overload the tendon too much. Just walking, just ambulating is putting load through the tendon. You've got to understand that some of these patients aren't tolerating the load that's placed on the tendon day to day. So they're out working, they're out doing what they need to do to make a living. And then we're loading them up even more when the tendon's not coping. What I try to do is get the pain down first. As they get their pain down, they start moving better. You start breaking some of those maladaptive movement patterns. And then it's that point that you can actually start, I suppose, loading them more effectively. And that's when you're going to get better bang for your buck with loading programs and things like that. So that's my approach. When it comes to which tendons does it work in, it works best in tendons with a paratene on. So I consider things like sort of greater trochanteric pain syndrome, patellar tendinopathy, Achilles mid-portion tendinopathy, plantar fasciopathy. These things it works very well for. The tendons that have sheath, such as your, the peroneal tendons, if you get a longitudinal split in a peroneal tendon, they either settle down or they don't. And if they don't, they generally need a surgical repair. There are many patients that have these sort of the tendons that run within a sheath, like your peroneals, your tib post, tibialis posterior tendon. If it's through the midpoint of the tendon and you've got a split there, shockwave I don't think has a heap of. I've treated patients over the past. I would say mixed results. It generally works reliably on those big, strong, powerful tendons and fascia. That's what it works very well for.
Great, thank you so much. We're right on time here. Doesn't look like we have any more questions. If anyone has any more, please put them. I don't know if I asked this, sorry. Do you use shockwave for osteoarthritic pain?
Yep. I do. I do have the occasional patient. You've got to choose the right patient because it's uncomfortable depending on where you're treating, particularly if it's around an ankle joint. It's very bony sort of areas. One case that I had was a man in his sort of, he'd be maybe late 40s. He suffered a fracture dislocation to his ankle. Several years later, saw me with considerable post-traumatic osteoarthritis. His ankle was very stable. He's got a sort of pretty pes cavus foot type. There's no real ankle instability. So the use of bracing and stuff wasn't really indicated because he doesn't have an unstable ankle. It was more just stiffness and pain. And he runs his own business. He's on his feet all the time. So I did talk to him about shockwave, and he was really interested in just trying something. And he did really well. osteoarthritis is a degenerative condition. There is no cure for it. It's around management. So in his case, we were able to reduce his pain. I did a series of, I think I did 5 sessions, and then we used to just do sort of monthly sessions, and then spaced out as needed. It's a bit different to a tendon because it's not necessarily, it's not necessarily going to resolve completely. One of the factors with osteoarthritis is when it goes into a really acute phase, often what happens is as the subchondral bone breaks down and you start to get fluid into that, and you get these subchondral cysts, you get microfracture. That's when the pain can get really severe, and they're almost in a stress fracture type state. And this is when this happens in the hip, it happens in the knees in particular, where you can have patients, and the degree of cartilage wear and tear doesn't always correlate to pain, but when you start to get these breakdown in the subchondral bone, and you start to get these bone marrow edema lesions and sort of subchondral sort of microfractures, that's when the pain really increases. Shockwave may have an effect with that. Probably more so the focus shockwave would be probably more indicated in that. But I have treated patients with osteoarthritis, and again, it's about setting expectations. I'm aiming for, with that, a reduction in symptoms. I'm aiming for an improvement in some function. But I think I will much more likely say we do a course of treatment, and then we may need sort of, once a month or once every few months, you find that sort of time frame where you space the sessions out to keep the patient moving as a non-surgical approach.
Thanks so much, James, for the detailed answer.
It's all right.
Really helpful for our participants. That's all of our questions. But if anyone has any other questions, please feel free to send them through to us, and we'll send them along to James. But James, thank you so much.
My pleasure.
Yeah, really enjoyable, and some great feedback in the chat from everyone that said it was brilliant. And obviously you be back for more after that comment.
I will. And look, I appreciate everyone's time on a Thursday night. I really wanted to keep this I'm not an academic. I'm a clinician. I wanted this to be clinically focused. I want you to be able to have various things that you can take home and start implementing tomorrow. You're all very intelligent people. I don't need to read articles to you. There's a lot of, there's considerable evidence base for shockwave, and you're well aware of that.
Right.
So thank you.
Thanks, James. Have a good night, and I hope you can put your feet up now, James.
Fantastic.
Cheers. Thank you. Thanks,
See you
guys.
later.
Bye.
Bye.